Today's agenda begins with a presentation that provides a brief study overview and information on the definition and development of the affected community for this study. The study overview is intended to provide context for today's discussion. A more detailed study overview presentation was provided at the first meeting, and a recording of that presentation is available on the study website. We'll put a link to that in the chat. Following the study overview and affected community presentation, we'll open it up for your feedback and questions. We have about 30 minutes allocated for the presentation and discussion of this topic. The remainder of the meeting will be dedicated to the topic of comparison communities. We'll have a presentation on what a comparison community is, its purpose in the study, criteria for identifying appropriate comparison communities, and comparison communities that have been identified to date. We'll then open it up again for feedback and discussion on this topic. And we are aiming to conclude tonight's meeting by 7:30. Next slide, please. To allow for more of a workshop style meeting, there will be a few ways to participate during tonight's discussions. You may verbally make a comment or ask a question, or you can submit your comment or question in writing via the Q&A box. We'll also be using maps on the Zoom whiteboard to collect specific geographical suggestions. So to make a verbal comment, please raise your virtual hand. This can be found by clicking the reactions icon on the bottom of your screen and then clicking the raised hand icon. You will be able to unmute when it's your turn. Right now, participants are muted just to avoid accidental disruptions during the meeting. If you're more comfortable asking your question in a written format, please use the Q&A feature, which can be accessed by clicking the Q&A icon on the bottom of your screen. If you see that you have the same question that somebody else has already asked, please upvote that question by clicking the thumbs up button, which is underneath the question. Just ask that you not use the Q&A function for editorializing about somebody else's questions or comments. And also want to note UCLA staff may answer a few simple, straightforward questions with written responses in the Q&A box, so be sure to look for those. The chat feature will be used tonight just to send out information and links to you as we already have. I'll explain the whiteboard tools when we get to the first map. You're welcome to raise your hand or place your comment in the Q&A box at any time during the presentation, but please understand that we will complete each presentation before opening up the discussion. We'll try to get to as many questions and comments as possible within the time that we have tonight, in particular focusing on the two methodology topics that are the subject of this meeting. So thank you in advance for understanding if I need to move us along in order to make sure we cover all of the agenda items tonight. The meeting is being recorded and will be posted on the study website. If you do not want your likeness to be recorded, please leave your video off when speaking and remove any photos of yourself from your profile image. We will also post the PowerPoint presentation. Next slide, please. We ask that everybody agree to a few simple meeting guidelines just to make sure we maintain a comfortable, safe, and civil space for this meeting. And these are: treat all meeting participants' comments and questions with respect. All ideas and points of view have value. Challenge ideas, but not the person voicing the ideas. Use common conversational courtesy. Inappropriate language will not be permitted. Stay focused on today's agenda and please honor the time that we have. With that, I'll turn it over to Dr. Michael Jarrett to introduce himself, the UCLA team members here today, and to provide the study overview and affected communities presentation.
Thank you, Lisa. My name is Michael Jarrett. I'm a professor of environmental health science in the Fielding School of Public Health and the co-director of the Center for Healthy Climate Solutions. I'm the contact principal investigator of the Aliso Canyon Disaster Health Research Study. And we have a really terrific team, and I want to introduce some of our leadership and people that are playing key roles. Let me start with my co-principal investigator, Dr. Honghu Liu. Maybe Honghu, you can just wave to the people. Dr. Liu is the program chair in population health in the School of Dentistry. He's also professor of biostatistics at the Fielding School of Public Health. Next, I'd like to introduce Dr. Wendy Robbins, who's a distinguished professor of nursing in the nursing school at UCLA and a professor in the environmental health science department. Next, I'd like to introduce Dr. Jesus Araujo. Dr. Araujo is a professor of medicine and cardiology and has extensive experience in toxicology and air pollution research. Next, I'd like to introduce Dr. Natty Pratt, who's a professor of health policy management in the Fielding School of Public Health. She's our lead administrator person. And I realize I didn't tell you what Drs. Robbins and Araujo are doing. They're leading our health component. So we're very fortunate to have people with their expertise to guide us in that respect. And then we have our extraordinarily organized and on top of it, project manager, Ms. Christina Battiati, and someone who is known to several of you in the community because she and I were out measuring air pollutants as the only independent scientist at that time working on the disaster, Dr. Diane Garcia Gonzalez, who is coordinating many of the exposure-related studies. So I guess we can shift now to the presentation. If you could put the slides up, please. Next slide, please. Our study is driven by three key research questions. And the first is, did exposures to the Aliso Canyon disaster adversely affect people's health in the past and currently? Secondly, do ongoing emissions from the facility adversely affect people's health? And then finally, can we link the health outcomes to specific exposures from the Aliso Canyon facility? Next slide, please. We have really extensive health and well-being assessments being undertaken. We're searching for evidence of exposures and adverse outcomes with blood samples in the babies that were born to mothers that lived in the impact zone, through the heel sticks that every baby in California gets. We'll be doing extensive metabolomic analysis on their blood. We have 600 adults, some in the impact zone and some outside in control areas, who will also be giving blood that we can analyze. We're going to be asking an extensive questionnaire about physical and mental health experiences and well-being in the community and in control areas. We're going to conduct clinical examinations of residents in conjunction with the blood draws and the other biosamples we'll be collecting. We're going to examine changes in health and mental health status that occurred after the blowout disaster. We're going to examine patterns of healthcare utilization before, during, and after the disaster. And then we're going to also study the prevalence and incidence of cancer. Next slide, please. We have really two major data sources. One is existing data that's available from various state and UCLA entities. This includes adverse pregnancy and birth outcomes, which I've already alluded to, but we also have the neonatal blood spot biomarkers. We have data on cancer from the Cancer Registry. We're drawing healthcare utilization data from the so-called HCI database, which has all hospital admissions and emergency room visits across the state. And then the California Health Interview Survey is hosted at the UCLA Fielding School of Public Health and the Center for Health Policy Research. So we have data on very detailed health questionnaires that have been taken repeatedly in our population representative across California. And then we're collecting new data that involves an in-person clinical exam and the biomarker study I mentioned earlier, and conducting this extensive survey of health, physical, mental, and health and well-being, as well as augmenting that with qualitative focus groups so that we can understand what people experienced during the disaster and how that might continue to affect their mental health and well-being. Next slide, please. We're also doing a lot to try to characterize the environmental exposures. So we're trying to assess the composition and the amount of emissions released from the facility. We're examining how those emissions travel through the air and were transformed into other pollutants as they were reacting. And we're trying to understand where the emissions landed and how those were translated into exposures in human populations that were affected by the disaster or could be affected by ongoing emissions. Next slide, please. To do this, we have several components in our exposure assessment core. We'll be conducting, beginning next month, indoor and outdoor air monitoring in homes within the community and in control areas. We'll be also sampling raw natural gas and doing analysis of the composition. And this is so we can better understand the gas that is likely being stored in the Aliso facility. And that will help to inform our health studies and our risk assessments, but also our atmospheric modeling. We're conducting very detailed atmospheric chemistry modeling. It's called a chemical transport model. I'll talk about that more in a few minutes. And we have remote sensing, so 5 satellites where we're drawing information on the distribution of methane during the event and on an ongoing basis. So we can better understand the spatial extent of the likely impacts, because methane is a sentinel marker that for natural gas and many of the air toxics that are of health concern are bound up and highly correlated with methane. And then finally, we're conducting a quantitative environmental hazards risk assessment. And this is not meant to substitute for any of the health studies that I mentioned earlier. It's meant to complement them, because there will be some instances for rare health outcomes where we won't have a large enough sample size within the impact zone to conduct formal statistical analysis. But by examining the risks and what's known about those exposures, we can infer whether or not the exposures could be something that would lead to future health problems for the people that were affected. Next slide, please. We're just in the first year of our study, which started officially in December 2022. We've already put in place all of the needed data and research infrastructure and the ethical approvals that are required for us to conduct research that protects personal privacy. We've begun gathering all the existing survey and environmental data. As David Eisenman said, we're engaging the community, and this is our second round of meetings. We're collecting new environmental data, and we're recruiting households to host air quality monitors. We've begun assessing adverse birth outcomes that could be related to the event, and we're soliciting technical expertise and guidance from our scientific oversight committee, which has 15 members who are all respected scientists with relevant expertise. Looking to year 2, this is a 5-year study, but we'll be recruiting people to participate in clinical exams and the surveys. We're going to continue the analysis of existing data and solicit more technical advice as needed from our scientific oversight committee. Next slide, please. I want to now shift to looking at how we define affected communities, or the affected community in the impact zone. I'll start with a presentation, and then we're going to shift to a question and answer period, and so we can discuss whatever concerns you might have. Next slide, please. So when we think about impact zone and affected community, these are areas that are likely to have experienced exposures before, during, and after the event. So i.e. that they're, say, affected by the plume from the disaster leak and by routine or ongoing emissions from the facility. And when we define this zone, we have an analytical trade-off that we don't want to have it become so large that we mix people that were exposed with those that were unexposed, because statistical theory tells us that that will reduce our chance of finding health effects, even if they are there. But if we go to much smaller areas that are much more precise, the sample size to conduct the health studies could be too small for us to find differences between the affected community areas and the comparison communities. Next slide, please. So in our effort to identify the affected community, we've used satellite imagery of the methane plume during the event, a chemical transport model. We've looked at the reports of health concerns and where the people lived. And then we've looked at the data that we have in our initial birth outcome analyses to see how sensitive it is in terms of the sample size when we go from various different buffers around the facility. Next slide, please. So as I mentioned, we have 5 satellites that are all capable of retrieving methane. You can see that the date range, a lot of them started just in 2015. And in fact, when we look at the field, the Aliso Canyon blowout disaster has spurred a much greater interest in what we can do with satellites to better understand methane distributions globally. So there's been a lot of work that's been done since the disaster, and we're fortunate to have Dr. Dan Cusworth and Miriam Marley are both leading experts in remote sensing to help us to retrieve these images. Next slide, please. On the left panel, you can see the Aliso Canyon facility and the adjacent Porter Ranch and other communities. Then in the middle panel, you can see the region that was likely affected by the plume during the event. And you can see that this is roughly about 3.8 to 4 miles before we return to normal background levels. Next slide, please. We did have a few days during the event that we've been able to obtain retrievals where the wind direction changed and the plume tended to be smaller in those days, about 1.6 miles, and largely was not affecting immediate residential areas. So most of the concern that we have in terms of the impact zone are areas to the south of the facility because the wind was predominantly from the north. Next slide. The chemical transport model is illustrated here. So all the components that go into a chemical transport model are shown. And that includes a very detailed emissions inventory from all possible sources that can lead to atmospheric pollution. It also includes photochemical and multi-phase chemistry. So Dr. Mike Kleeman is a leading expert in this area from UC Davis, and he's helping us to fit these models. And you can see that we've also got particle physics, cloud formation, and then wet deposition and dry deposition of the particles, and other events such as wildfires that can affect air quality. So the real strength of these models are that we can isolate what specific sources are contributing to observed ambient concentrations of the air toxics of interest. Next slide, please. This is some of our initial results from the chemical transport modeling. And this outline in black is just for context to show you the Porter Ranch area. These are 1 kilometer grids, so they're about 0.4 of a mile. About 0.25 of a mile. And, you know, what we can see here is that the higher levels shown in the darker colors were predominant, very close to the leak site, and that we do get influence that goes into the community and is elevated for methane, going to about 4 miles away from the facility before we reach background. Next slide, please. One of our biggest concerns from a health perspective is benzene, because it's known as a group 1 carcinogen. The International Agency on Research on Cancer has determined that it causes cancer in humans. And this is an example of what we can do with a chemical transport model. We can look at the emissions, and what we're doing here is showing emissions in the right panel that are directly from the facility itself. And then on the left panel, all levels of benzene. And unfortunately, despite many years of progress through regulations that have been promulgated by the South Coast Air Quality Management District, we still have, compared to other cities, fairly high levels of benzene across the Los Angeles air basin. So it's important for us to be able to separate these out from what's standard background level and what was emitted during the event. Next slide, please. And I should say that we see about the same for benzene, where there's about a 4 mile impact zone before it returns to the background. And if we look at toluene, another air toxic of concern, we can see that there were certainly emissions that were associated with the concentrations that were observed around the community, that they were highest where the leak was occurring, and that they tended to diminish as a function of distance away from that leak. We see roughly the same level before we get to the background, where it's around 3.5 to 4 miles. And what we do see as well is that the area that has the light industrial manufacturing zone and the railway running through it, Chatsworth actually has much higher levels than what came off of the Aliso facility. So this is one of the challenges we face, that we're not looking at just a pristine background environment and what this facility did, but we have to take into account these other sources of air toxics, and we're actively interrogating the emissions there to understand better what's causing that and what impacts it could have on the community. Next slide, please. So just to summarize, the data that we have from satellites, from the chemical transport models, and from field measurements that I haven't shown you, indicate that the impact zone is likely 4.4 to 5 miles to the south of the facility. During the disaster, when people were expressing concerns about their health or odors, about 83% of those concerns were within the first 5 miles from the facility. When we look at the initial analyses that we've been doing on adverse birth outcomes, we get a much smaller count if we try to go into, say, 3 miles from the facility, whereas at 5 miles, we have sufficient data to be able to differentiate the birth outcomes that occurred during the event, or where the mother's pregnancy intersected with the event. And we can differentiate those from other control areas. So the objective exposure data, the health concern data, plus the initial analysis of the health outcomes and the field measurements all suggest that the impact zone is about 5 miles to the south of the facility. Next slide, please. This just shows a map where we have the leak site, the SS-25 wellhead, and the first red half circle is the 3 mile radius. The next yellow one is the 5 mile radius, and we've shown all the zip codes that intersect. In some cases, we can use precise locations, say the residence of the mother that gave birth. In others, where we have hospitalization data, we have to use the entire zip code because that's the smallest resolution we can obtain it at from the state government. So some of the issues we wanted to discuss with you are, whether you feel are certain areas that should be included or excluded. Are there other things you want us to know? Are there specific concerns about this impact zone and specific recommendations about how to change it? So I'll shift now to the discussion period for the impact zone and the affected community.
Thanks. Sorry for the disruption. We just wanted to make sure we were getting this recorded properly. So, yeah, as I mentioned, please feel free to raise your hand or place a question or comment in the Q&A box. And as a reminder, if you are raising your hand and giving your comment orally and you don't want your image recording, to please turn off your video and remove any photo. If I noticed there may be one or two people who joined us just by phone. So if you would like to raise your hand, it's *9 to raise a hand so that you can make an oral comment. I'll alternate between the raised hands and the Q&A box, trying to coordinate comments at the same topic. We want to make sure to give everybody a chance to speak at once. So ask if you can keep your comments concise just to make sure we can get everybody in and to focus on the affected community topic at the moment. I mentioned before that we were using a whiteboard. So we'll have that map on the screen and that will allow you to make a comment directly onto the map. The purpose of this tool is to capture suggestions specifically tied to the geographic area. For example, if you want to point out an area that should be included or excluded, or identify geographical factors that should be considered. And looks like we're getting that whiteboard up right now. Just want to note, for other comments, non-geographical or just general, please use the Q&A or verbal options. The map is going to be used to collect information, but the focus of our conversation will be on the oral and written comments. Just a few instructions for anybody that is new to this tool. We're requesting that you use two of the tools shown on the left side of the map, the pen and the comment tool. To draw a line, click on the pen, and then you can move your cursor to the map to draw the line. You can use the comment tool to explain the reason for drawing the line where you did. To do this, click on that comment icon on the left and move your cursor to the map, and then click where you want to place the comment, and then you can start typing. You can also click on a comment that somebody else made to see what's written and add or respond to that comment. And just please note the meeting guidelines about appropriate language apply to this map as well. Just also want to note, we're giving this feature a try for this meeting in order to expand the ways in which we collect community feedback. But we understand that if a number of people are using the map and adding to it, it may become difficult to see, or it may not be intuitive or user-friendly to everybody. So if we run into issues, we may have to discontinue or change course. So thanks for your patience in advance with this experiment that we're doing tonight. So with that, I see we've got a few hands raised and we'll open it up for discussion. When I call on you, I will invite you to unmute. So we've got Julie K is first.
Can you hear me okay?
Yes, I can.
Good. I was just recalling that shortly after the methane explosion, many of us went and had our blood work done. I think Dr. Nordella was the one that put that together, because I remember going, I think on Balboa Boulevard, someplace where I had my blood work done, and then I got the results. Are you all aware that that took place? I don't know how many people were involved, but I would imagine there were a lot of people.
Yes, during the blowout disaster, I was in regular contact with Dr. Nordella. and gave him some suggestions about what would be, appropriate contaminants to try and test for in the blood. And then we followed his subsequent presentations and his writings on this. And we've looked at the control areas that he used to compare some of those biomarker results. So yeah, thank you. We are aware.
So you are aware of it, and you've seen the results. How many people had their blood taken at that time? Do you know?
I think it's about 103 to 105, depending on the assay.
Okay. I was, wondering if that's probably as close to the actual event, certainly much closer than now.
Yeah, definitely. So we're hopeful that we can work with Dr. Nordella. We did invite him for some consultations as we were working out our consultation plan, and he declined to participate. So possibly in the future he will. I'm not sure.
Thank you.
Thank you. Next we have Alvin.
Hi, sorry, it took me a second to unmute, but one thing that I just kind of wanted to ask and follow up on, because I was at the first meeting, the first community meeting that was held at Pierce College. And I guess one of the concerns that was brought up was the sample size being relatively small and not fully representing the full population that was impacted. So I'm just a little curious if that concern's been addressed, because I guess what just kind of flagged this for me was hearing that there's a sample of 600, and please correct me if I'm wrong.
Well, no, you're not wrong. That's for the clinical exam and the biomarker assessment. But we do have, complete population representativeness for the birth outcomes, for the cancer instance, for the hospitalization. So all of that is very complete data for the entire population. And with the 600 clinical exams and biomarker assessments we're doing, the extent of the analytical work that we're conducting on the blood should allow us to identify subtle differences, if those indeed exist, between the people living in the affected community and those living farther away in control areas. As a scientist, I'd always like to have more data, but I think for this kind of assessment, it is quite an extensive amount of data. And we're working with Dr. Dean Jones, who's the world's #1 expert on metabolomics and how we can identify thousands of contaminants or intermediate biomarkers that could be indicators of or prognostic indicators of future disease risk.
Thank you. Next we have Isam, and please correct me if I mispronounced your name.
No, that is correct. That is my name, Isam Nejam. I have a couple of questions and a couple of comments, if you'd allow me. First, on the transport model, I just want to ask if the transport model does take into account the unusual behavior of the gas as it was emitted in your assessment of the distance it traveled and how it dispersed, because not only was it under high pressure, but also there was a strong temperature differential. And I don't know if the dispersion and transport models accounts for that. I think that's important to include.
Yeah, I agree. And we recognize that, in some instances, despite the high pressure it was coming out at, it became a negatively buoyant plume, meaning that, it was colder than the ambient air and therefore heavier. And what we're doing in the next phase of the modeling with Dr. Kleeman's colleague, Dr. Holly Allrod, is looking at the topography and particularly honing in on those canyon areas where that kind of plume could be brought into the community. We certainly see evidence of that the canyons were probably playing a role in the dispersion of the methane and then associated air toxics into the community.
I want to ask you if you have all the online data and grab sample data that were collected, and not only did AQMD collect grab sample data, but also there was this extensive Air Resources Board online monitors. And the reason I bring that up is in my analysis of the grab sample data, and I hope you can undergo that analysis yourself, especially the samples from within the facility, there was a clear correlation between benzene and methane. And what that allows you to do, if you find it and if you believe it, then it allows you, as you said, use methane marker to project the dispersion of the other chemicals, because the ability to measure the other chemicals with the grab sampling approach was very difficult. It's a hit and miss when you have the winds blowing, but the methane plume that you're able to record is a great marker for it if you are able to technically establish the same correlation between the two.
Yeah, so I mean, we're doing everything we can to obtain as many of the data samples that were taken during the event. We have a public records request in with the South Coast Air Quality Management District to obtain all the data that they monitored with during the event. We have people from the California Air Resources Board on our scientific oversight committee. So they've been helpful in pointing us to the right areas to get those data. So, in addition to that, the data are very useful for cross-validating the chemical transport model. So
One last comment on the, I'm sorry.
We're still working on it, but we're headed in that direction. So we're trying to get as comprehensive a database as possible.
Okay, and if you're interested, we have a repository of all the PDF files of the lab reports that were posted during that event, and the Excel files that I'd be glad to send them to whoever you'd like to.
Oh, that would be great. So we'll follow up with you after the meeting.
Sure. Sure.
Thank you.
The last point I want to make is the concept of the background. Is the background that you're going to use as a background chemical exposure, is that a regional background or is it going to be a locational background? Because that's the challenge we have in the concept of a background when AQMD was talking about it, because they're talking about a background from the station down in Burbank. Well, this is not Burbank. Burbank has an airport. Burbank has a lot of industrial activity. So I'm not sure that that's a good background. I don't know if you have enough locational background information to work with.
Well, in terms of direct measurements, we're probably about as limited as, the government samplers that were out, and our own measurements that we were able to take in places like Northridge, 10 miles away during the event. But the chemical transport model gives us estimates for every kilometer, and we're working to bring that down to every half kilometer, so 500, about 5 football fields. And that will be across the entire Los Angeles, air basin. So we'll be able to localize those background levels based on our model predictions. And, part of what we're doing is trying to correlate those with available data so that we can understand how well they are predicting the monitoring locations. So far, they've done a very good job. And I think part of that is that Dr. Kleeman's been working on this kind of modeling across California for more than 20 years. So he really understands the science that's behind it. And, so we will be able to localize it to backgrounds that are, say, much closer than Burbank.
Okay.
Thanks. Thank you.
Thank you.
Next, we have Richard.
Hi. First of all, your That's not your picture.
Your impact zone data is absolutely terrific. And you are in a position immediately, if you give this data back to regulators in SoCal Gas, maybe it would really help an existing situation. And here's what it is. This disaster never would have happened if there was an operable shutoff valve at the bottom of the blown out well. It could have been shut off, and the impact would have been minimal. SoCal Gas is currently saying they don't have to have shutoff valves at the bottom of every well because the regulation says they only have to have it if there's any people or infrastructure within 300 feet of the well. Okay, well, the impact zone is 4 to 5 miles, not feet. And if you can get this information on the impact zone back to them, maybe you can turn some heads and get them looking at installing shutoff valves at the bottom of all operable wells. And I would even go further. If they don't do that, then we have to start saying or continue saying that they need to shut down that facility because it's not safe. A colleague of mine has done a study of SoCal Gas's earthquake impact study on their field, and he has found some real problems with that study. And the risk is a lot higher than they're saying. So I just wanted to throw out those comments. You're in a position to get this data immediately back to them and not wait 2 or 3 years. You could do it today.
Wow.
Thank you.
Yeah, I mean, we want to make as much of this information as public as possible and to have it be as useful to the community, to SoCal Gas and to the regulators as quickly as we can. We do try to put all of our work through a peer review process. So it does take a little bit of time, but in the end, that gives it more credibility. But we do also have, regular meetings with the South Coast Air Quality Management District and their staff that are working in the Aliso area. And we're also working with people that are setting up the monitoring system from Argo Scientific. So that information is finding its way back, I think, and hopefully we can put these into papers and get them out there very quickly so that they have even more credibility after they've gone through the peer review.
Thank you. I want to note that we were having some technical issues with the whiteboard, but it's back up if anybody cares to put a comment on that. We have Christine up next.
Well, I could turn on the camera right here.
Hi, actually, this is Craig Galante. My wife, Christine, and I are sharing screens tonight. I apologize. I was dialing remotely and I may have missed several things, but I do have a couple of questions. The first one was, I just didn't quite understand the granularity impact, Dr. Jarrett, on the zip codes. What government data is only down to the level of zip code rather than like census tract or something like that? Could you rephrase that? And I got another question too, please.
That's all the emergency room visits and hospital admissions.
Okay.
We would like to have them on a much more granular scale, and we're working with the people at UCLA Health to try to access the data that they have. The limitation is that that's not population representative. It's purely a function of who's enrolled in our healthcare system. But with those data, we hope to get them down to the household level. So we'll have an additional source of information on healthcare utilization. Dr. Pratt is working with that group at our campus now.
Okay, so you may have ability to get to the household level detail so that you could do some groupings more along the lines of what you're anticipating the exposure to be.
Yeah, and
potential.
For the adverse birth outcomes and for the cancer incidence, we either have in hand the geocodes of the person's house.
Right.
So or we've ordered the information so that we can geocode it ourselves. So it's really just the data on ER visits and hospital admissions as population representative that we're limited to zip codes.
Okay, thank you for that. So my other question was, and maybe you're going to get to it later, but how are you exactly going to control when you control for the Aliso factor, the Aliso impact, the Aliso exposure? You know, it works both ways. I do agree with some when we heard the comparison to Burbank and benzene levels. You know, it was kind of positioned as, well, you don't have anything too much to worry about. The benzene levels are very similar to what's over at Burbank, and Burbank obviously has an airport. So, you know, we need to have clarity to how the Aliso factor will be isolated from your control groups and how it will be isolated from any other petrochemical operation. And then I'd like to hear that answer. And then I have a comment about Dr. Nordella if you have one more moment.
Can I quickly say that is the topic, that's going to be the subject of our next topic is comparison communities. So we're going to go into that in detail.
Okay.
After your last question, and then we have one more question by Lori, and then we're going to get to that.
Excellent, thank you. So just a comment about Dr. Nordella. What Dr. Nordella took a pass on was the survey regarding the efficacy of DPH, the CAG, and the SOC. Dr. Jarrett, I could say with firsthand knowledge, if you want to talk medicine with Dr. Nordella or someone on the senior staff of the study, he is more than welcoming that sort of dialogue.
Well, thank you, Craig. We'll make sure that we follow up and contact him.
Please do. And if you need any help with that, let me know.
Thank you. I appreciate that.
Great. Thank you. Next up, we have Lori.
Yes, can you hear me?
Yes.
Yes, I have a question involving something that occurred during the blowout. There were days during the blowout when I didn't smell that horrible stench of mercaptans that usually made us all vomit. When I wasn't smelling it, I was still getting very extreme health symptoms and felt terrible.
Mm-hmm.
So I'm wondering, I've always wondered if that's because some of the substances that we were exposed to were gases and some were heavy metals, which I assume are heavier. And I don't know if any of the gases were heavier, but can this be taken into account in the study in terms of exposures? Like how can you work that in?
Yeah, that's a good question. I guess, firstly, we do have a fairly extensive set of measurements that were taken in the indoor environments. And that was really prompted by some early measurements that Dr. Garcia Gonzalez and I did that looked at, and found some elevated levels of benzene and then hexane in residences that had been affected. And we're really in that direct, Porter Ranch Estates area where it was really directly downwind. That led to a fairly extensive indoor air study, which metals were in the particles that were measured. The statistical analysis we did indicated that there was likely penetration from the outdoor environment of heavy metals like strontium, manganese, barium, antimony, that were occurring in an unusual cluster together that was unlikely to have occurred by chance. So when we worked on those data, we indicated that we felt this was sort of a fingerprint that there had been emissions that were penetrating to indoor environments. And that certainly could be one of the causes of your symptoms when you weren't smelling mercaptan. So we're working on that. We're also trying to obtain, and we have obtained some of this, all of the information on the well kill materials that would have emitted particles. We know that there were several shelter in place orders issued or advisories by the gas company when they attempted to kill the well with muds and salts and injecting those into the leak, there was definitely some material that was emitted during those events. So we realized that that's potentially very important for understanding the health implications, and we're putting a lot of effort into trying to characterize that. We would like to be able to get every single sample that was taken, but that's something that, we may not get because they're proprietary, and I assume that they may have been part of the lawsuit and may be, locked down at this point.
Thank you. So let's move.
Glad-
I'm sorry,
Oh,
Lily,
I'm
just have a quick follow-up.
Glad to hear that you are trying to take that into account, because I've always been curious. Thank you.
Yeah, my pleasure. Thanks for the question.
Thank you. So let's get back to a presentation on comparison communities.
Thank you. If I could just get the slides again. So when we try to choose a comparison community, we're looking for communities that are closely matched demographically, socially, economically, and environmentally to the affected community. But we want communities that are outside of the affected community and are unlikely to have been directly affected by pollutants released during the blowout or from ongoing emissions. And when we have that information, it allows us to employ very powerful statistical methods to assess whether the affected community differs from the comparison communities in key health outcome trends. And I'd like to show you an example of how these models work. So if we had, for example, comparison communities that had a slightly lower incidence of diseases, say adverse birth outcomes, than the Aliso community, but they were tracking at a very similar level over time, what we can do with that comparison community is say, well, in the absence of major confounders that are missing, we would expect that trend to be the same as it was before the blowout. If we do observe that the affected community after the blowout has an increasing trend, we can say that these are likely the health effects that would be attributable to the impact of the blowout. So with these models, we can assess both the initial differences that might exist, but very importantly, when we're looking at the blowout disaster, we can determine whether or not we see differences in the trends. And we use that comparison community to give us a way of statistically simulating what would have happened in the affected community without the blowout, which is shown in that dashed green line. So we have the green comparison community, the likely trend in the absence of a blowout, and then we can observe what actually happened. And if it's larger than what we would expect from the trend analysis, then we can infer that this is likely due to the effects of the blowout on people's health. Next slide, please. And the data that we've used to conduct our analysis for control communities are demographic, so race, ethnicity, and age structures. We've used income and the percent of people that are homeowners versus renters. We've extracted air pollution data from the statewide Cal Enviro screen for PM 2.5, so particles less than 2.5 microns, so they're respirable, and for ozone, which is a gas that is very health active in many ways, but causes oxidative stress in the lung. And then climate variables, oftentimes inferred by location and climatic classification, and then trends in health outcomes before the event. So there are several practical considerations that we have to think of. For example, the feasibility and logistics of, say, if we're doing the air pollution monitoring and we want to set up monitors in the affected area and control communities that run simultaneously. If we have to go out to Riverside County and Orange County every time we want to put out a monitor that's matched to somebody in the affected community, it's going to really be logistically challenging and difficult to implement. We do have, like any study, although this is a large study, we have cost constraints, and we have, you know, statistical validity issues if we start breaking up the samples. For example, someone, you know, asked about the 600-person biomarker sample. We wouldn't want to take the 200 people that we're going to have in the control communities and split them up into 200 different places. We want them to try to share some common characteristics that are something that's easily interpreted with the affected community. And depending on the health data that we have, we can determine the selection of comparisons, and in some cases we have a lot more flexibility than others. Next slide, please. I mentioned the existing data and newly collected field data. This just combines it in terms of the health and environmental data. But the existing data, I won't go through all that again, but you can see that a lot of it's there. And then I guess we could have also put in all the exposure measurements. And then when we look at the newly collected data, we have those in-person exams and the biomarker studies, and then the surveys. And then environmentally, we're going in and doing these measurements of indoor and outdoor air pollution, as well as the raw natural gas, unburned natural gas compositional analysis. So for the existing data, we have a lot more flexibility because there's statewide coverage for most of these outcomes. When we get into the neonatal blood spot analyses, they're very expensive, and we're going to do, I think, 2,400 in total. So we won't be able to do unlimited numbers of comparisons, but we will have a lot more flexibility than we do if we're looking at the newly collected field data, especially the health and biomarker exams. Next slide, please. So in our initial efforts on this, we've used what's known as the community analyst. It's a geographic information system software that allows us to demographically match different areas across the Los Angeles metropolitan region. And you can see all these areas in green match up based on population characteristics, income, race, housing. And you can see the yellow area and the impact zone shown around Aliso Canyon. Next slide, please. Here, we're showing the green areas and blue areas, which are control communities. We've eliminated here all of the coastal comparison communities because they either have very intense oil and gas development, which we felt could contaminate our comparison, or they had a very different climate that would have introduced a lot of other heterogeneities. So what we have left then are the blue areas in Simi Valley and Thousand Oaks that we consider to be good comparison areas for those studies for which we have logistical considerations of less flexibility. And when we go to take the clinical biomarkers and Dr. Robbins' nursing staff has to go into the field, we have to do that in environments that are suitable for people to undergo these clinical exams. We can't necessarily execute that like a mobile clinic all over the region. And as I mentioned, for statistical reasons, we wouldn't want to. And it's also a good area to do the pollution monitoring because climatically it's very similar. There is a mountain range in between the two of them that acts as a blocking mechanism. So it's unlikely that the area was heavily influenced by air pollution from the leak, and especially given that most of our evidence suggests it's 5 miles to the south. So we consider that to be a good area for these newly collected data. All of the others are demographically and environmentally matched. So we can use those for studies for which we have more flexibility. And in some instances, just like Dr. Nordella, we can look at statewide levels. We can also look at all across the Los Angeles metro. But these are, in our assessment, our best control communities. So blue and green indicate areas that would be good for the existing data for which we have more flexibility. And you can just, I don't know if I mentioned this, but the black dots are all of the oil and gas development areas. Next slide, please. So when we look at the comparison communities for the existing data, we've got a lot of flexibility there, but we still feel it's important to match as carefully as we can on the demographic, socioeconomic, and environmental conditions. But as I mentioned, we can have a lot of different comparisons and do sensitivity analysis on those. So that's something that we're undertaking now in our birth outcomes analysis. And we expect to have results from those analysis that we can report back to you early in the new year, 2024. Next slide, please. This is where we really like to get your feedback about your thoughts on using the Simi Valley and Thousand Oaks as a comparison community for the newly collected health and environmental data. Do you see any issues with the comparison areas that we've identified in green for the existing data? Do you think that there are other criteria that we should have been using to select these control communities? And is there anything else in general that you'd like us to know about why you think these communities would be suitable or not?
Thank
Next
you.
slide. Sorry, Lisa.
Oh, no worries. I thought you were finished with the presentation on that.
Yeah, I'm finished. Thank you.
Okay, so yeah, we're going to open up the discussion on this. We had an issue with the whiteboard. There was at least one and perhaps a few other people that weren't able to see it. So just in fairness, we're not going to use it if everybody's not able to access it. So we're gonna stick with this map here and the oral and written comments. So we've got a few hands up. Let's see. Okay, so let's start with Isam.
Thank you. On a couple of the areas, I'm surprised Encino did not register as a blue area. I thought that would have been the perfect demographic comparison to us here. I'm not sure if there's any reason that it didn't make the cut.
Yeah, when we were, before we started doing the data comparisons, I thought that as well, but the racial ethnic mix of people there is quite different than what you see around the affected area. So that's why it didn't survive the initial analysis.
And I would suggest that you stay away from the San, I can't remember the name of it now, the San Gabriel Basin, and looking at a Flint Ridge, because while it looks perfect, there is the groundwater contamination challenge there from JPL and Aerojet and everything else that may confuse the background comparison information. So I would suggest you stay away from those.
Okay, thank you. I appreciate that comment. We'll take that into account.
Thank you.
Thank you. We have Julie next.
Let's see, about the area, the Simi Valley, Thousand Oaks area, using it as a comparison. I think you have to be careful because of the Santa Susana Field Lab and what has gone on there for the past 50 years. I'm not sure if Isam was mentioning about the water contamination, but he said San Gabriel Valley. But the contamination, they're literally going to begin cleanup. I think they said spring of 2024. Where the first, it's burn pit 1. They're going to start transporting thousands and thousands of acres of polluted land. So I don't know. I'm asking you the question, is that I mean, does it get too convoluted and too mixed up? What do you think?
Well, I think that's a really good suggestion and we should look into it. I think that is a Superfund site.
It is.
My sense would be that if there was off-site contamination, it's probably in the form of dust or perhaps vapors that are coming from the contaminated soil. We can look into that, and we can also put the emissions inventories that we have to look at that specific facility. And it may be that we don't want to include areas that are potentially impacted by dust or vapors that will be coming off that field site.
Yeah.
So I appreciate.
Yeah.
This is exactly the type of feedback we were hoping to get from local residents who have such a deep knowledge of where they live. We do our best with the models and interviewing people, but you know, and certainly if other thoughts come to mind after the meeting, please feel free to contact us. But we'll look into that in detail. Thank you.
Thank you. We have Craig up next.
Yeah, thanks. Yeah, I agree completely about the Simi Valley area regarding the old Rocketdyne testing. That's a pretty nasty area. The other question I have is the black dots. Are these active oil facilities? And what about the abandoned? Because there's typically a lot more abandoned than I'm seeing here.
Yeah, these are active. And then there is the other active storage site at Playa Vista.
On a rancho, yeah.
So yeah, these are active wells. We didn't include all of the closed wells.
Well, we know that that's a problem. So I think that is the challenge. How do you get away from petrochemical? Because the inactive wells, the vast majority of them, as we're discovering, they were never sealed properly. So there's quite a bit of emissions there. So I think the next view of this should include a layer of the abandoned wells as well.
Okay, yep, we'll take that. We'll get those data. I know that it was quite a challenge for us to get an accurate coverage of the active wells. I think it's somewhat easier, and Dr. Garcia Gonzalez and Ms. Battiati could comment on that more specifically, because they were working on the data that was coming from the state government.
Yeah. I forgot the new name for Dogger, but Dogger has accurate mapping for both active and inactive.
Yeah. So we'll have a look at that. I mean, of course, there are a lot of inactive wells that are right underneath the community in Porter Ranch and other areas.
Oh, so you're suggesting maybe that would be, well, see, but that's the thing. So it would be, we need to isolate the variable, right? We need to isolate the blowout exposure and the ongoing operation exposure and the historical operations, because it was an oil field well before it was a gas storage field.
Yes, yeah, and it's definitely a challenge, you know.
Yep, I knew it would be, and yeah, so I appreciate this direction.
We were concerned about that after the leak was sealed, and we did go out and do quite a bit of monitoring at locations that were close to capped wells in the Porter Ranch area, and we didn't find any really substantial elevations over what we were seeing in other locations. So, and we particularly targeted some of the earlier wells too, that on the grounds that they may have had more lax regulations. And some of them, I think, from doing, you know, readings and looking at some of the historical literature, they really just had boards put over them and nailed down.
Right.
So we didn't see any evidence But that's something that, you know, as we go into the field and do some monitoring in the community, I think that it's a good idea that we should probably try to interrogate that issue a little bit more again, now that we've got even better equipment to use.
Well, Christina's already responded that the inactive layer of the mapping's turned off and you guys could turn it back on. So thank you. If you could do that tonight, that would help. That would help answer the question that you're posing to us. Does the blue area look like a good comparison zone? So if we can get that tonight, that would expedite things.
Thank you. We've got Matt up next.
Can you hear me?
We can.
This is Matt Pacuco from Safe Porter Ranch. One of my concerns is the freeway adjacent versus which way the winds blow. Up here in the north end of Porter Ranch, it's pretty clear to us that the wind comes from the north, so we're not getting much north or the west mostly. So we're not getting the freeway effect at this end. I don't know what it is at the down, next to the freeway, but at some of those areas I was looking at in like Thousand Oaks and stuff, I don't know which way the wind blows from that 101 into these neighborhoods. So they got to take that in consideration, that you're not just measuring, freeway gas.
Yeah. Yeah, it's been interesting. We've been doing mobile monitoring. So driving routes repeatedly where we have methane monitors and particulate monitors throughout the areas that are close to the facility and then into Thousand Oaks. And we are generally finding lower levels in Thousand Oaks than around the facility. And we've been trying to get days where the wind is coming from that prevalent, north-northwest direction. And lately, anyway, there have been a lot of days where the wind is coming from the south. And we're not sure why we're seeing these anomalous conditions, but certainly, we're getting on some of the field monitoring days where it's really coming from due south. So there would be some freeway influence. And oftentimes too, the influence of freeways is affected by whether it's nighttime or daytime. So some of those prevailing winds actually reverse directions in the evening, or they become much less of a factor. But we're definitely aware of the proximity of the freeways, and we're going to try to be picking areas that are comparable. We can't completely avoid them because Los Angeles has such a huge network of freeways, but we also have extensive experience on our team with measuring traffic related pollution. So Dr. Yifeng Zhu's done some of the seminal studies, and I have as well. We just finished up a large California Air Resources Board study where we measured particles repeatedly in 46 locations and developed models of, all of the land use and transportation system variables that could predict those levels. So, that's part of the data that we have at our disposal when we start working on these either health studies or the air pollution studies. We can then take that data and compare to see whether or not the objective data are being influenced by any of those near source emissions.
Yeah, I wonder if there's any way to figure out what the air would be here without that facility. One reason we moved here was because we thought we had this breeze coming off of the mountains, and little did we know what we were stepping into. But it would be nice to be able to take that out of the picture and see what air quality would be. I don't know if that means going to an unpopulated area just west of here, or if that even matters inside this study. But that's
Well, one of the things that we can do with the chemical transport model is we can get those shots of all emissions, and then we can get the emissions that are coming specifically from the Aliso facility, and then we can subtract one from the other. So we can develop those estimates and show them to you at a future meeting. So you can see, if you removed all the emissions that we're aware of, from the Aliso facility, what would the air quality be like? And how much would you see an improvement? So we can definitely do that.
Okay, great, thank you.
Okay, thank you. I'm seeing there is a question in the Q&A box, Patricia, but I'm gonna continue on the topic of comparison communities, and we'll try to get your question answered on biomarkers if we have time, if that's okay. So we've got Bruce next.
Hello. I noticed that your map does not go far enough west to include the oil wells that are offshore. I'm wondering if you can use your methane camera to see what kind of emissions are coming from there. I would also note that prevailing winds are usually west to east. So I would think you could also use the prior data that you've gathered to look during the main blowout period to see if there was anything that was drifting to the west in the Simi area. I suspect not, but it looks to me like a pretty good area. Thank you.
Thank you for that comment, and we'll definitely look at that. So far, we're not seeing evidence that there was a lot of impact in the Simi Valley area. And on a sort of routine basis, Dr. Kleeman's models do take into account marine emissions. So if there are offshore oil production facilities that are emitting, those would be already integrated into his estimates.
Thank you. Julie is next.
Okay, I'm sorry, I forgot to ask before, and it may not be exactly to the comparison areas, but just something that I've been thinking about. We're talking about air emissions and the pollutants and toxins and all of that. What about, did anything get into the ground when it rained? Did it get into the groundwater? I don't know if we have local wells. I just have no clue.
The to my knowledge, the water supply is a municipal supply, so I don't think anybody there is on a well. So the immediate impact of groundwater contamination would not be, I don't think, serious. The emissions that could be deposited and then transported through soil, having soil brought in as people, come into their houses and they leave their shoes on and that sort of thing. I'm hopeful that as we get better information about what was in those muds that were used to try to kill the leak, and some of the information on the screens that were put over the leak site to try to understand the composition and the indoor samples, at least we will be able to better link that up and determine. But I mean, just as hazarding a guess, I don't think the volume of particulate matter material that would have fallen would have been large enough to really result in a huge amount of soil contamination.
Thank you.
Thank you. Craig. And I understand that Diane and Tina are working in the background on that map, so hopefully we can get that.
Excellent. So appreciated the hard work. Thank you. Actually, when we're done with this conversation, my other question was about the comparison of other communities and how you were doing. There's a few slides back. So as soon as we can, I would really appreciate if we can go back to that. So let me know when you're ready to do that. If we can do it now, great. If not, I can wait.
I'm sorry, I think I spoke too soon on the map about sharing that map. Maybe it takes more work than maybe it takes more work than we thought to get it up with all the outlines and everything. So
yeah.
Sorry about that.
So then if you have more questions or conversation about the maps, let's have it. If not, I'd like to go back a couple of slides because I had a question about the comparison over timeline.
Diane, are you able to go back a few slides to the,
Keep going backwards. There's the line graph with the hash line
that
this
one?
one.
Yeah.
Yes, this one. So I'm very concerned about this affected community without the blowout, the green hash line. So if I got this right, you anticipating doing some sort of projection of what the health incidences would be if the blowout didn't occur? Isn't that incredibly hypothetical? And
Yeah, I realized that as I was going through this and you know, we tried to generalize it a lot, but let's say, you know, that the period that we see before the blowout starts in 2012 and the period that extends out farther. I think there was a new slide where we were trying to make this a shorter period, so it didn't look as lopsided, but we're going to go out to probably in the, you know, range of 2022, something like that. So it's not going to be projection into the future. It's going to be the actual health data that we observe. So that will show whether or not there are elevated rates or incidence of disease.
Right. Well, what I'm going after, what I'm having a hard time appreciating is how you're looking at this gap between the green hash and the red and saying that's the impact of the blowout. And in my mind, that you can't do it that way. You look at the comparison community, and if their incidences of health or disease goes down, and the community around Aliso goes down, but not as much, you have to look at change on change between the two groups, not this hypothetical hash line, because that's just a dampening factor. That would be a great way to introduce a way to say, oh, well, yeah, we saw an increase, but we think, 90% of it would have been there anyway. That just doesn't, I don't see how you can have any sort of forecast without a blowout.
Yeah, so I mean, the terminology you used is very close to what the models are called. They're called difference in difference models.
Yeah.
They do assess, maybe in the interest of generalization here, I've taken out too much, but they will assess whether or not there are changes in the comparison community. So say, for example, the comparison community had a big drop in its incidence of low birth weight babies. We would then see that dotted line adjust, so it would go down as well. So we're basically making the assumption that, if before the event, these communities are well matched and they're following similar health trends, that after the event, we would expect them to follow similar parallel lines. And what we observe, if it goes down in the comparison community, that will influence the affected community without the blowout. And then we can actually observe the affected community with the blowout. So the comparison community becomes a means of generating what in statistical terms is known as the counterfactual. What would have happened without the event? And that's why we really try to match them very closely on many of the key characteristics that could be both related to the trends in health, if people are, and try to match them in a way that the prior periods are parallel. And we do a lot of assessments of that when we're doing the empirical analyses with the actual data.
So I'd like to talk about this some more, maybe have it shown to me in more detail. I'm just not buying it. I would look at the comparison community went down 5%. The affected community with the blow up went up 6%. You've got a delta there that described that there's something going on. Or if the affected with the blowout goes down, but not as much in a percent change, you still have an issue, a contributory issue of the blowout. So I don't like the difference between the hash and the affected by a pure count basis. I just don't think that's a sound way to do it. But I'm not a statistician. I just intuitively, it just doesn't seem acceptable to me. I'd like to see it both ways. If you're insisting on doing it this way, I want to see it both ways.
Well, I mean, when we present these graphs empirically, we always present the actual trend lines that were observed in the comparison community, and then what was observed in the blowout, affected community. So that's always something that we report, so you can see it graphically. But the way of getting our counterfactual is to say, and it could very well be that there are some health outcomes where, the level that we start off with in the Aliso area is identical or very, similar to the comparison community. So those lines before the blowout would essentially be one. And if that was the case, it would be essentially doing what you're suggesting we should do. But if we do start off with these different levels, if we don't take that into account when we're developing our counterfactual, we're in all likelihood overestimating the impacts of the blowout, because the community started at a higher level in this instance, and we'd expect them to maintain that higher level.
Well, that's why I like change on change, because it takes into consideration the baseline for both control and test.
Yeah, so if we were to lay out the statistical model, I think you'd see that it is a change on change type model. But this is just a graphical way of trying to illustrate that the role that these comparison communities play.
Thanks. I want to note that it's 7:29, but we're willing to go a little bit longer than 7:30 to make sure we get all the questions answered. So if you guys are also willing to stay with us, we welcome that. Looks like we've got Matt has a question. Sorry, I need to ask you to unmute. There we go.
Can you hear me?
Yes, we can.
Yeah, the Santa Susana Field Lab thing, I think you were saying, Dr. Jarrett, that you're trying to somehow assess whether or not to use that place. I think you should just, because there's a limited budget here, just carve a big wide swath from the east Simi Valley to the west San Fernando Valley, and just take it off the map, because there's plenty of other places. Because that went on for so long, and that place is so many problems. So many of them are unknown. Just take it out of the picture.
Sorry, Matt, maybe we should put the map up again, and because I'm not sure if I understood your comment.
The SS Santa Susana Field Lab in the West San Fernando Valley, that the nuclear disaster and plus everything else. That's what I'm referring to.
So are you suggesting that area be carved out of that blue comparison area?
Yeah, carved out. Don't even waste any time or money or effort on that. Just to completely exclude.
Yeah, I know where it is in general, but I haven't looked at it in a while. So, but yeah, we can definitely exclude those areas. And I know that Dr. Beata Ritz did some of the first studies on the Rocketdyne contamination, so she's pretty familiar with that as well. So you're saying remove anywhere that's near the west end of the Thousand Oaks Simi Valley area, close to the field station. Is that right? Or
I don't know how far towards Thousand Oaks, but definitely West San Fernando Valley and East Simi Valley, and
okay.
even parts of Chatsworth, because it early on in the blowout, we heard SoCal Gas and company saying things kind of referring to some of these effects can be attributed to Rocketdyne. They were freaking saying it.
Okay.
I'm gonna say it
So-
again. They're gonna say it again if you go anywhere near that.
Okay, well, these are really important remarks, so I appreciate that. And we'll go back to the drawing board and try to make sure that we're not picking anywhere that could have been influenced by that field facility.
Thank you.
Okay, and I noticed that Patty says in the Q&A that the red area is in the Santa Susana Field Lab. I'm not sure if you're referring to the dark red for the zip code map. So that's in the impacted community, the impact zone. So take a look
Yeah,
at that.
look like the west edge of that red area would be included.
So that's more in the affected community on this map, it seems. But thank you. We'll look into that.
An overlap.
So we have a comment in the Q&A from Patricia. You might be able to compare hospital admissions before and after the blowout for Providence, Holy Cross, and Northridge Hospital, the two largest hospitals in the area. You might also contact other private medical practices that existed both before and after the blowout and the types of illnesses they saw. Any
I think well, all of those will be captured in the HCI data, not for routine encounters, but for emergency room or visits and hospital admissions. What we might be able to get from some of the private providers, and that's why we're working also with UCLA, is to get more finely grained data. I've worked for many years with people from Kaiser Permanente. The data are very good from what they have. However, it's extremely expensive to work with them because those data have to be analyzed by their own staff. So I don't know if Dr. Barat wants to make any commentary on that. She's leading that part of the study and is an expert on healthcare utilization data.
Hi, thanks, Mike. The comment about hospitals, we're definitely looking at the hospitals. We were looking at, particularly, we need to know which hospitals most of the individuals living in these communities go to. So that comment is right on target. In terms of data from outpatient, generally, we're talking about doctor visits and other types of outpatient services. That's where we're spending a lot of our effort trying to find out the best sources of that data. Whatever data we will have has some limitations. For example, UCLA data, as Mike said, or Dr. Jarrett said, are restricted to individuals that used UCLA as a provider. Kaiser, the same thing. We are investigating whether it is possible to talk to some health plans because they have data. Again, those kind of efforts are seriously complicated because anyone who has data requires us to pay very large fees, and that's a big challenge. We're just trying to figure out where we can get data that are informative, and together all of the data should tell us reasonable information about the health impact in terms of utilization.
Yeah, thank you very much. Yeah, and just to put it in context, I think I'd have to go back and check the budgets, but I just finished two large studies, relatively large anyway, maybe with a combined budget of about 1.4 million on COVID and air pollution. And we worked with the people from Kaiser, and out of that 1.4 million, that was probably 900,000 went to them. So it's not an inconsequential component of it. And we considered that when we were putting the proposal in. and felt that, you know, at the margin, that maybe wasn't where we wanted to be spending as much of our money, that we wanted to put it more into doing the neonatal blood spot analysis, where we can do before, during, and after the event in the affected area and in the comparison areas, and into the clinical exams, which we understood from consultations with the community were a big concern, that and you know, quite legitimately, that they wanted to see what was going on right now with people's health, and with Dr. Rahu and Robbins and Eisenman and Ritz and others. You know, we've got a very comprehensive series of clinical exams that'll look at everything from mental health and functioning to blood biomarkers. So we had to make some of those choices. I do appreciate though the recommendations that, you know, we can go to some of these local hospitals and try to get the data, and possibly we'll be able to access some UCLA data. UCLA has a fairly large presence in that area too. So, but
Thanks. We have a question next from Lori.
Yes, I was curious on the map where you're showing a comparison area in Santa Clarita. It's difficult to tell the map because it's small, how near that is to the Rancho Honor, I think it's called Honor Rancho natural gas storage field. Is that a concern, that it's too close to another natural gas storage field?
yeah, so that's something that, you know, and you can see also if we go into Anaheim and some of those areas in Orange County, that there's some pretty heavy oil and gas development there. And our plan is to use them as demographic matches, but then to conduct sensitivity analyses where we don't include those areas that are very close to either active storage facilities or active wells. I think, you know, we can try to avoid the capped wells as in the sensitivity analysis. I can't remember how spatially extensive they are, but I think there's quite a few of them, so it might be more challenging to do that.
Okay, that was a concern. Thank you.
Thank you. We've got one or two more comments in the Q&A box. Patty's noting that the Department of Public Health sent out a directive in March 2016 to health providers, which discouraged doctors from considering Aliso as a cause for health problems. And then we've got a question from Craig regarding the cancer registry. Will the study be able to compare incidents within the target zone versus like comparison groups specifically, or the target area versus the entire county?
Okay, so on the cancer incidence question, we'll have the access to the geocodes, so that will be at the residential address. So we can do comparisons with any of these demographically matched areas. We will have the capacity to look at the whole county. But we feel that it's probably a stronger study designed to stick with these matched areas. So we will have that capacity. I'm sorry, there was a question before that, and if I could get that one repeated.
Let's see. Will the study be able to compare incidents within the target zone versus like comparison groups specifically? I think it's one question, or target areas versus entire county.
Yeah.
Oh, and the other one was just kind of a comment. Patty was providing some context regarding the medical records, noting that Department of Public Health sent out a directive in March of 2016 to health providers, which discouraged doctors from considering Aliso as a cause of health problems. I took that more as a comment.
Yeah, I'm aware of that, you know. we can't really go back and do anything about it. But
And there was one comment that we didn't get to. Thanks, Patricia, for your patience, because it's on a little different topic, but since we've got a few more minutes, Patricia was asking what biomarkers will be monitored in adults, and will these have any value 8 years after exposure? I know we talked about this at the first meeting, but maybe we can give a quick answer tonight as well.
yeah, so I might draw on Dr. Rahu and Dr. Robbins and Dr. Eisenman to answer that. I think their expertise is in those areas more than mine. But
Sure, I'll go first. I think that it's a great question, and what we did was we looked at the exposures and what is known about health outcomes related to exposures, and then we tried to identify markers that we might have related. So, for example, benzene has been shown in workers to actually cause change in lipid metabolism, and over time, what you would see would be abnormal lipid profiles. We are doing metabolomics, which will show us traces of perturbations that might occur in normal metabolic pathways or hematologic pathways. And so we'll be able to identify those and then look at current day tests, for example, complete blood counts and platelet counts. And we're going to do those. We're going to do comprehensive metabolic panels. We're also going to look at immune and inflammatory markers. So the acute effects, changing pathways that later manifest in certain diseases, is how we've done our literature searches to come up with our list of biomarkers. I hope that helps, and others weigh in.
yeah, I could just follow on to that we will have the neonatal blood spots so that we can look at the before, during, and after pregnancies. And that, I think, is a real strength, that we have biomarkers and we're applying metabolomics to those so that we can look at thousands of different chemicals in the blood, even from these very small samples now. So if there are subtle differences that could be the kind that would indicate certain types of exposures or potentially adverse processes biologically, we should be able to detect those. So those are measurements that are, human specimen measurements before, during, and after, versus the ones that we're taking now 8 years after.
Thank you.
We will be able to differentiate, whether the comparison communities have different profiles in terms of their blood biomarkers than what we observe in the current community. And we understand that community members are still probably concerned about what's potentially coming from the plant and whether that's resulting in any clinical or biomarker differences.
Thank you. I want to know, I see a question or two might be popping up, but I just want to note for anybody who is going to drop off, and thanks for sticking with us a little bit later, that we do ask if you would fill out an evaluation form for us so we can just continually improve these meetings. And the link is in the chat, and we'll also be sending you the link in a follow-up email. So we'll keep going with a few more questions. Maybe we'll try to wrap a little bit before 8, but in case anybody has to drop off, I just wanted to mention that. The comment in the question in the chat was if we can get a list of all biomarkers and blood testing that's anticipated.
Yeah, we can provide that.
Okay. And then we've got a raised hand. Kyoko, you're up.
Hello, can you hear me?
We can hear you, yes. Go ahead.
Okay, hi. I have a lot of questions regarding to cancer registry. And it's, I probably don't know that much about it, so I'm just kind of, ask. Could be question, but where that cancer registry actually come from for this study, and like what kind of date do you choose, like a specific period of a year? And then when you have that data, is it choosing from like, specific address? I mean, I have no idea about this, and I want to know.
Yeah, so these are data that are routinely collected by the state of California. And in the case of LA County, by the cancer registry that's lodged at the University of Southern California. And it's basically a record of every new case of cancer and cancer death that occurs in the state. And we have the capacity to extract out very long runs of data. There's usually about a 2 to 3 year lag in the data that we can get before it becomes publicly available. So, say this year, if we went to get it this year, it would go up to 2021, maybe 2022 by the 2024 period. And then we'll be looking at a period beforehand that's sufficiently long that we can track whether the trends in the cancer incidence are different in the affected community compared to the control areas.
So everyone, sorry.
No, sorry, Dr. Liu is leading that part of the study, and he's already put in the data request. I'm not sure if he's still here, but if he wanted to share what dates have been requested.
Yeah, I'm still here. Yeah, we already applied. We actually applied both the entire LA County cancer registry data, and because we were looking at the comparison community, which is outside LA County, like say, for example, the Simi Valley area, some of those actually outside LA County. So we applied also the entire California cancer registry data. As Dr. Jerry mentioned, this actually capture every single case of the cancer occurred in LA County, actually the entire California. And not only the incidence, prevalence, and also the follow-up, the trajectory, the over time status. And so we have this geocoded for every single case. And we will be able to look at this affect area over time. And we'll be able to compare with look at the comparison with other communities in terms of number of years. We actually now looking at the up to date, we have about 2021 cancer data available. 2022 is about ready to be released also. And we actually go back about almost like 20 years of data we will be able to obtain.
So every single person diagnosed or treated or follow up is in the cancer registry. Even the patient, didn't do anything or fill out anything. Any patient from every single hospital or any medical place in California, it goes to the registry, or the data goes to the registry?
Yes.
Yeah. Yes.
I mean, there could be some undiagnosed cases where someone dies and it's not known they had cancer, and it gets wrongly attributed to another cause on their death certificate. You know, maybe that could be a natural death or something if the person's very old and they didn't know they had cancer. So there's some aspects of it where there could be that, it's called a case ascertainment bias, where you would have someone that had cancer that doesn't get diagnosed and dies before they can be diagnosed. We might miss some of those in the registry data, but every other case is recorded.
Okay, let's take one last question from Julie, and then we can wrap up.
Do you do it, the study, this registry, by zip code? How do you, is that how it's done? I mean, how do you look at the Porter Ranch area within 5 miles or whatever the area is, and then you look at the registry to see what the cancer rate is and the type of cancer?
Well, we've requested the geocodes of all the cancer patients and cancer deaths. So that means that we can convert their addresses into a longitude and latitude, and we can locate them within that 5-mile area versus the control areas.
So at the end of the study, you're going to be able to say that there's this percentage of a particular cancer, breast cancer, bladder cancer, whatever. You'll have something like that in the study showing the area?
Yeah, I mean, for privacy reasons, we're not allowed to share that data. We have to undergo strict ethical review for that. We won't be putting any maps out that say, here's where people that had breast cancer lived. But there are ways that we can anonymize the data and show overall patterns that could be of interest to community members.
I mean, will you be able to, in doing your comparison areas, show that there's a greater percentage of a particular cancer in the Porter Ranch area versus another control area and comparison area?
Yes, we can do that. Cancer is probably one of the most challenging diseases to study because it has a long latency period. When we get the data on where the person was when they're diagnosed or died, we don't know where they lived before that. So, let's say somebody lived in Long Beach right beside the port for 20 years and then retired to Porter Ranch. It wouldn't necessarily mean that they'd gotten the exposures that would have led to their cancer at Porter Ranch. So we do have, limitations based on the latency. The other challenge we're going to face is that, even though it's a leading killer, cancer is still a relatively rare event in the population. And when we look at those zip codes, we have a population of around 76,000 people. So if you're expecting, one cancer for every 50,000 people every year, it still may not over, even an extended period of time amount to that many cases. So that makes it harder to detect differences between the areas that have been impacted potentially by the facility and the control areas.
Okay. Thank you.
Thank you. We're going to wrap up. Dr. Jared, if there's any closing statements you want to make before we turn to Dr. Eisenman to say a few notes about community engagement and send us off.
Well, I'd just like to thank everyone for their really active participation tonight. I think we've had a good workshop. We've got lots of things to think about and some really valuable insights about the field facility in Rockadine that we hadn't considered before. So if you have other comments or questions that come up after the meeting, we're more than happy to either talk to you or respond to emails or phone calls.
Perfect. Thanks so much. And a perfect segue to turn to Dr. Eisenman on some of the links for contacting us and the evaluation.
Yes, well, I just want to reiterate to what Mike said. I mean, We really thank you for your fantastic questions. Your really probing insights. This was hard material, and you ask really great questions, and it's going to improve the study because it's making us think things through differently, and that's exactly the value of this community engagement. So thank you for attending. Please spread the word about these events so more of your neighbors and friends come to them. Our website and Facebook page are there, and email sign up. I'm sure you're on that. If not, get onto it. And we'll be sending you an evaluation, a link to an evaluation form. Please fill it out. Give us written comments too. We really value them. We want to get better. This is not Yelp. We're not looking to sell anything. We're looking to get better. So please fill out those evaluation forms, and we'll be seeing you in the months to come at future community engagement meetings. Thank you.
Thank you all. Have a good night.
Thank you.